And as you can see from the slide, I'm a medical specialist. My business is, treating patients and making them better. I'm not so much an expert in reprocessing, although I'm trying to become one, because I do believe that there's an area that we have been largely neglected in the past few years. And I think we all, particularly probably you in the audience, but more people in the field are recognizing this as a very important area that we have to improve upon. Because, and I will show you in my presentation, this is important for us as professionals, but more importantly for patients. I'm working in the Erasmus Medical Center. It's the largest academic center in the Netherlands. And to give you some hint of what we do about 15,000 endoscopic procedures per year in my unit. So that's a large volume. And if you look, by the way, this is my disclosures. If you look at this worldwide, and this is a slide that I could find about endoscopic utilization, and this is from the year 2000, 2010, so this is not so recent, you can see the numbers of, let's say, what I would call simple endoscopy, like colonoscopy or EGD. In the US, more than 3 million on a yearly basis in 2010, more than about 3 million EGDs. I'm sure that will have been doubled by now. If you look at the complex scopes, and that's mainly the topic I'm going to talk about, that's ERCP in the US. You can see ERCP already in the US like 300,000. I'm sure that will have been doubled by now. But in particular EOS, 64,000, I'm sure that will be now in the range of 500,000 because EOS has kind of emerged as a very important endoscopic tool to stage patients with all kinds of cancers. This is just the US. So imagine on a worldwide scale the number of endoscopic procedures that we do on a daily basis, including, if that's true, the risk associated with doing endoscopy. And I will show you that there is a risk with endoscopy. Now, just for some of you who might not be so knowledgeable on the subject of complex scopes, what I call complex endoscopes are ERCP scopes. And these ERCP scopes we use mainly to treat bile stone disease in the biliary tree, but also to drain the biliary tree and pancreatic duct in patients with all kinds of cancers. And you can imagine that scope that has a side viewing optics, it has a working channel, it's an elevator, it's quite a complex design. And we put a lot of devices through that working channel and we pull stents through it and debris and sludge of stones. So it's a lot of wear and tear on those scopes. Now, EOS scopes, a very other important tool now in my profession. This is a tool that we can use diagnostically. We do a lot of what we call fine needle aspirations to diagnose, but also stage patients with cancer. There you see an example of a malignant lymph nodes. And we have these small needles that we can put through the working channel of the scope and then advance into a lesion of interest and try to sample cells, and the pathologist can tell us what we are dealing with. But nowadays, we also are using these scopes for more therapeutic reasons, in the sense that patients with severe abdominal infections and large collections that are necrotic and infected and kind of abscesses. In the old days, the surgeon would do a laparotomy and open up the abdomen, and I can tell you that was kind of the last thing you would encounter, because then you would probably die because of that procedure. Nowadays, we do that all non-invasively, at least non-invasively. We do it through the normal openings of the body, the mouth or the anus, and we go in with those scopes and we drain those collections. But you can imagine the bioburden those scopes go through if you drain transgastrically or transduodenally such a abscess. So a lot of wear and tear on these scopes. Now, if you look in the literature, you will find an incidence of infectious ERCP complications between like 2 and 4%. But I'm very sure this is a huge underestimation of the problem. And it has to do with the fact that you have to recognize that an infection in a patient in hospital is caused by a scope. And so many patients in hospital have an infection or fever, and you're not always logically then kind of bind that to the ERCP procedure. So in particular, if there's a multi-drug resistant outbreak, then in the hospital, as a physician, as a specialist, as somebody responsible in the hospital for infection control, you are alerted to that problem. And I will show you an example in my own hospital why we got alerted to this problem and why I got so interested in this subject. There's a lot of failure in hospitals, not only in community hospitals and academic hospitals, about adverse event reporting. There's a huge underreporting, and I'm very sure that in the smaller hospitals, it was just never identified. It was just not noticed, and people thought that the problem of the patient, the infection, was caused by something else. Now it's important to realize if you talk about infection with the use of these scopes, there are what we call endogenous sources of infection and exogenous sources. The problem, of course, is that with these scopes, you go through the mouth, to the esophagus, into the stomach, and these are all environments that are not sterile. So whenever you do a procedure, when you open up something, when you make a hole, when you remove something, a polyp, you create a defect in the mucosa. And that can also then cause endogenous bacteria to cross that barrier and cause a problem in that patient. You can try to get around by this, for example, by using antibiotics, but you cannot go around by this by changing something to the endoscope or to the equipment. That's just a problem that's inherent to the procedure. But there are also exogenous causes with regard to infection. And there you have a contaminated scope that is being used in the patient, and that scope is contaminated with biomaterial from a patient previously treated with that scope. And obviously that is something that you want to avoid. You know, as a physician, the first thing you do when you get your final exams, you pledge an oath, and that's primum non nocere. First, do not harm. You're harming patients if you infect them with a bacteria from a previous patient. So if you then talk about contamination, very important, of course, breaches in the reprocessing of scopes. It's something that we should not neglect. I think that's still important. I'll come back to that a little bit later, but it's an important area. But also the complex design of scopes. The complex design of scopes kind of make it almost impossible to clean those scopes adequately, at least to a level that none of the scopes is contaminated after cycles of reprocessing. And I will show you some outcomes, some numbers of a study that we did nationwide in the Netherlands, and I'm very sure you will be kind of staggered by the results of that. That's something that we have to do something about. Now, the scale of the problem of scope infections is much bigger than many people believe that it is. Since 2012, more than 40 documented outbreaks have been reported in the literature, involving over 350 patient infections, and already more than 30 patients have died directly because of the scope infection. So not because of another medical problem, because of the infection of the scope, exogenous infection. So this is a very serious problem. And I will tell you later about an infection in my hospital, and I have to talk to those families. I have to talk to the patients and to the spouses and the children. And that's not an easy thing, I can tell you. This is something you really want to avoid. Importantly, these infections have also been reported without breaches in the reprocessing procedures, which means that there is a problem with the design of scopes. Because even if you adhere to all the instructions, still you're not able to clean the scope adequately. Importantly, when all this started to emerge, we thought it was kind of limited to one scope and one kind of scope design. I will show you that scope a little bit later, a lumpus scope, but now we know that's not true. It is a problem of all scopes, all these complex scopes. It's just the design that makes it so difficult to clean them. Now, what always surprises me, in particular when I read about this subject a little bit more and I was confronted with this problem, is that we have this process control of reprocessing according to the manufacturer's instruction. So the manufacturer tells you you have to do it like this, and then everybody says, okay, and we are done with it. And we believe that we are doing the right thing. Unbelievable in 2017, I would say, to be quite honest. And importantly, in my hospital it is now, we do a lot of microbiological surveillance, but this is not a routine practice. In fact, most hospitals don't want to do this because then you're confronted with a problem that your scopes are very often contaminated and you have to invest money in more scopes, and that's expensive. Now, if you look at scope reprocessing, I find this a very interesting slide. Maybe you know this. For me, this was a revelation, to be quite honest. Because if the scope comes out of the drying cabinet and you have used the scope in a patient, then you have post-procedurally about a 8 to 10 log 10 bioburden. Then you start with the manual cleaning process, very important, one of the most important steps in the whole cleaning process. And then you're able to have a 4 to 6 log 10 reduction of that original bioburden. You then start the automated cleaning process in the automated high-level disinfection, and again you add a 4 to 6 log 10 reduction in bioburden. Now, if you add this up, this is 8 to 12 log 10. If you subtract them, there's a very limited margin of safety of 0 to 2 log 10. Now, if you compare that with what we have, if you have a process of sterilization, it's 17 log 10. So that tells you why this is such a intrinsic process which is so vulnerable and why we have scopes that are not adequately disinfected. Now, this is a detail of a complex scope, and you can see this is a scope where the cap could be removed, or can be removed. You can see it over here. But still you have this very complex design. Here you see what we call an elevator, and this is a working channel, and through the working channel you can put out instruments that you can kind of lift with that elevator. Very important to be successful at the procedure. But you have a lot of intricate surfaces. It's difficult to clean already. Now, a few years ago, one of the scope manufacturers thought they would make life easier for us, for you, by having a scope design with a cap that was fixed. Because then you don't have to remove it, maybe more easy, faster to clean. And also the channel by which the elevator was moved with a wire was kind of closed with what they call an O-ring. Again, to make it easier, at least that's what they thought, with regard to reprocessing. The problem is it was not, to be quite honest, and I will tell you why. Because we published a report in 2015 in Endoscopy about a major outbreak in our hospital of a Pseudomonas aeruginosa infection that we could link between a scope and the patient that actually got the infection. So we had epidemiological data to investigate the molecular typing. It revealed that novel designed duodenoscope, specific type, that was in use at that time, was linked to the transmission. So not only epidemiological data, but also biomolecular data. We were able to test the DNA from a tissue fragment that we got from the scope with the DNA of the bacteria of the actual patients, 20 in total. So there's no discussion about that. That infection in that patient was linked and caused by that infected scope. In the recess under the forceps elevator, difficult to clean, we found that small piece of tissue, human tissue, where that bacteria was also growing, which we could link to the bacteria in the patients on the ICU. When we stopped using the scope, the outbreak stopped. And we did a lot of investigations together with the Technical University. We dismantled the scope, we had electron microscope investigations, and independent experts of the university concluded that in particular that O-ring was a very important source of concern and contamination. And to show you a little bit more in detail, you can see this is a new scope, only have been used in about 50 patients, and already you see corrosion around the lens of the scope. This is the elevator, and this is the O-ring that is supposed to closely seal off that, the outside world from the inner working channel where the guide wire is running to move that elevator. But you see all kind of cracks and indentations, and we found fluid behind the O-ring that also contained the bacteria. Now, to understand the problem from my point of view, I had to talk with my people from the microbiology department, and we have these different kind of microorganism and categories to understand the problem. Of course, you have gastrointestinal and oral microflora, and you have skin and waterborne flora. The first two, for sure, are always originating from a patient in whom the scope was used previously. Of course, that's the important part. Now, if you look into the literature, you have various definitions that you can use when you talk about a contaminated scope. One is what I have called AM20, which means that you have more than one microorganism with more than 20 colony-forming units of any type of bacteria. So that could also mean skin or waterborne bacteria, which might come from the patient itself. The MGO are microorganisms with gastrointestinal oral origin independent of CFU count. And again, this is the important category because these are always bacteria from another patient. And these are also the definition that we worked with for subsequent studies that we did in my hospital. I'm going to show you some results that we haven't shown before to anybody, so you're the first. We did a study in the Netherlands, what we call the Process 1 study, where we cultured many ERCP scopes in the Netherlands. We did now the Process 2 study, and there we cultured all complex endoscopes, all ERCP scopes, all EUS scopes that I've just shown you. And we looked at the bioburden and whether these scopes, when they were hanging in the dry cabinet, ready for use in the next patient, were contaminated, yes or no. So prospective cross-sectional study, all Dutch ERCP US centers. We did a microbiological sample of all these scopes. We have in the Netherlands about 75 centers where they do ERCP, 62 were willing to participate, to cooperate, so that's still more than 80%, which is quite sizable. Many complex scopes, many samples. We had ERCP scopes, 185, and linear echo endoscopes, 57. We did a lot of cultures, and to just give you some insight, it's about 30 minutes work to do this in one scope, to do all these cultures. So we have the flush biopsy channel, where we took cultures, the flush suction channel, the forceps elevator, the biopsy suction channel on different sites. And depending on the scope type, we also cultured the protection cap, if we could separate it from the scope, the flush forceps elevator channel, and the flush air water channel. So many different sites of potential contamination we could look into. Now, this is the number of infections, so scopes that are contaminated according to the AM20 definition. So 13% of all the scopes hanging ready for use in the drying cabinets in these Dutch centers are contaminated according to the AM20 definition. I think that's something you cannot, this is something you should not want as medical professionals, either if you're a medical specialist or working in the reprocessing department. This is obviously something we don't want. You can also see that if you look at duodenoscopes or the linear echo endoscopes, there's no difference. They're both vulnerable. They're both the same kind of, between, let's say, 10 and 20. And also between the types of brands, there's no statistical difference. So it's the design, the complex design by itself that makes it so problematic. Now, even worse, it is if you look at scopes contaminated with flora from gastrointestinal or oral origins. So those contaminations from a previous patient. 15% of all the scopes hanging ready for use in the dry cabinets. Again, no difference between duodenoscopes and linear echo endoscopes, and no statistical difference between brands or types of scopes. It's not that, it's the design that's the problem. Again, between different scopes, because this is of course very important for the manufacturers to know that is not a problem that is based upon the design or type, both for the two definitions, AM20 and MGO. So complex scopes, 13% contaminated AM20, 15 with the presence of any gut or oral flora. Though 37% of the centers had at least one complex scope, so 1 out of 3 centers had at least one infected, contaminated scope hanging in a dry cabinet ready for use. And that's in the Netherlands, which I thought was a kind of a developed country where we did things right, and where, imagine in some other countries, and probably you can think of some other countries, I can think of some other countries, this must be much, 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 much worse, with all the inherent problems for patients. And I already explicated this, not confined to specific scope, brand or type. To me, this tells me quite clear that relying on process control is just not sufficient. It's crazy to rely only on process control, in fact. Now, what can we do? What can we try to do about this problem? I've listed a few things. Measures to prevent duodenoscope-related infections. Of course, we can do surveillance for infection after duodenoscopy, but then the problem already has occurred in an individual patient. So this is with hindsight, which also is good to know that something has happened, but it's not preventing the problem. There are issues with sterilization. I'm not a specialist in that area, but what people tell me is that it's very problematic because these scopes that each cost about 80,000 euros per scope are very vulnerable with regard to these kind of heat sterilization or kind of agents that are being used for sterilization, and that's just not working at this point in time. New generation of scopes, less complex tip design, easier to be cleaned, of course. That's a very obvious thing to do, and I will show an example of that. Scopes may be able to undergo sterilization. I'm not an expert, I don't know if that's even possible. And also disposable scopes, and it sounds like a crazy thing maybe to you, but there are now manufacturers that are really contemplating about designing disposable scopes, even complex ERCP scopes. And I already worked with some of these prototypes, and they do the job. The question, of course, is what's going to be the price of those instruments. Also process control, and then I mean active process control. So in a way that during the whole reprocessing of a scope, you build in some checkpoints, whether a scope is sufficiently clean, for example, after manual cleaning, to continue the process of the automatic disinfection in the machine. This, I think, is the most important message of my whole presentation, because this solution does not exist yet. And this, and I think it's forgotten very often, the manual pre-cleaning is the most essential step in scope reprocessing. If that's not done adequately, the washing machine will not do the job, and you will end up with a contaminated scope. Now, this is an example of some work that we have been doing with a scope manufacturer to change the design of the scope. This is a scope from Pentax. This is the old scope, this is the new scope. It doesn't look so much different. Up until the moment that you remove the cap, that was already possible at the older generation. But if you look now at the design of the tip of this new scope and the design of the tip of this older scope, well, it's not very difficult to see that probably this one is much easier to clean. Still, it has some intricate surfaces, but this is easier to clean. And you see this in more detail here. The trick is that the cap is not only removable, but also that movable part of the elevator can be removed. And then you have a much easier to clean scope where you can use indeed brushes to reach those areas that you cannot reach in the older generation scopes. Now, the reason why 3M asked me to talk to you about this is that we are doing some work in that area with the ATP test and I already alluded to that kind of checkpoint. So in the whole process of reprocessing scopes, that you build in checkpoints, for example, to test if the manual pre-cleaning has been sufficiently enough to continue the process of the automated disinfection. And that's where the ATP test comes into the picture. The ATP test is a marker for organic residue. It reacts with luciferase enzyme on the swab, and you have a luminometer that measures the amount of light generated. And it works very quickly. You can do a very rapid test after the manual cleaning, and you have a certain threshold that you can read on the device. And in the literature now, it's stated that a threshold of about 200 RLU is probably the threshold that one should use. If it's lower than 200, the process can continue with the automated machine disinfection. If it's higher than 200, you have to do something. You have to repeat the manual cleaning process. That's a hypothesis. We have to prove that, of course. There are a lot of ATP tests that have been done in the literature. The problem is that none of these studies are controlled. And in fact, none of them are very scientific with regard to the methodology used. And you can even argue if that cutoff of 200 is a cutoff that is really scientifically based, and even maybe if different scope types, for example, simple scopes or complex scopes, need different cutoffs, for example. That's something we have to find out. In my center, we are running together with 3M the DETECT study. This is a prospective single-center intervention study, and the primary aim is to assess if this test, the ATP test, lowers the number of complex scope that are contaminated with microorganisms of either gastrointestinal or oral origin, so the contaminations that matter. It's an investigator-initiated study. It's financed by a non-restricted grant by 3M, and the methods is that we do microbiological cultures of each reprocessed complex endoscope after each procedure. So a lot of work is being done there. And the research group is blinded for culture results in order not to influence any outcome of the study. We do the ATP test after the manual cleaning of that complex endoscope, and we have what we call a control period. So there we do the ATP test, but we are blinded for the results. And then we will have a second, the intervention period, where we do the microbiological sample, but then we will also influence the way we treat the scope based upon the ATP results. So the scope will go back into a cycle of manual pre-cleaning depending upon the outcome. You can see to show a reduction in contamination rate of 50%, we have to do a lot. We have an estimated MGO incidence based upon our studies in the Netherlands of about 10%. And then with a power of 80% and a significance level at 5%, you need more than 870 scope procedures to be included in the study. And if we do an inter-analysis and it shows that this estimated incidence is too high, 10%, it's lower than 8%, we have even to go up with the inclusions to 1,100 of these cycles. And again, each cycle is at least half an hour time even for swabbing and culturing. So you can imagine the amount of work. We have now 8 medical students that continuously every day do all these procedures with every scope and all these cultures. So we have a 40 milliliter flush of biopsy suction channel to do the work. We have swabs of the distal tip in the forceps elevator and cap. And again, for this study at this point in time, the threshold is set at 200 RLUs, just as suggested from the literature. If there is a persistent positive ATP test during the reprocess cycle, we repeat the test again, and then we kind of reprocess the scope. If there are more encounters, we just continue with use, because again, this is the first controlled study that really looks into the usability and the applicability of this test. And I'm sure because of its design, we will learn a lot about indeed the applicability of the test. So again, the flow chart of the study, the control period, bedside flushing, manual cleaning, we do the blinded ATP test, then the scope goes into the automated cleaning, we do the microbiological sample, and then drying or the next procedure. This is almost finished, this control period. And then we will start with the intervention period, bedside flushing again, manual cleaning, and then the ATP test is used as a kind of a guidance either to immediately continue with the automated cleaning in the washing machines or to go back into the process of manual pre-cleaning until we have a level, ATP level less than 200 RLUs. So we just started with the design already in the spring 2016, and it took quite some time to think about the whole design of the study, because a lot of work and of course also financial investment is involved with that. So we really took our time to design the study properly. We did pilot experiments and we had a lot of supporting staff to recruit to be able to do all this work. And we have been starting including patients from July onwards. In this year, we have now more than 350 inclusions already, and almost now are finished with the first phase of the study. And we're on schedule, so hopefully we'll have our results next year. So in conclusion, endoscope reprocessing option of mitigation. Infections transmitted by complex endoscope are real. There's no doubt about it, and it causes substantial burden. Of course, substantial burden for patients, but also for institutions, for physicians, for people working in the reprocessing of scopes. Very importantly, the problem is only going to become more prevalent because increasing number of procedures are being done where we do a lot of invasive work, where we cut sphincters, we open up mucosal barriers, so you have a mucosal breach and all kind of blood vessels are easily transposed to the outside environment, being more vulnerable for translocation of bacteria. And very importantly, we have more sicker patients, patients that are at increased risk. We treat now many patients that are on all kinds of immune compromising medication, liver transplant patients, kidney transplant patients, a lot of patients undergoing all kinds of treatments, chemotherapy for cancers that we treat now, all kinds of endoscopic treatments. And those patients are much more vulnerable for infections than other patients. In my mind, we cannot rely on passive process control. Butcher should not inspect his own meat because that's what's happening right now. That's what the scope manufacturers are doing. More vigilance and active microbiological testing, innovation to contain and ultimately solve the problem. I think this is pivotal. We have to have well-trained and motivated cleaning personnel that understand the importance of manual cleaning. This should not be the last step that you do when you organize an endoscopy department. It's the first thing you have to secure, safe and good cleaning of endoscopes. Active process control, so not passive but active, including ATP testing, question mark. I hope our study will provide that answer next year. Modification in scope design, easier to clean, resistant to more aggressive higher level disinfection, even sterilization. And I believe, and this is also something that's lacking now, if there is a scope design modification, the ability for adequate reprocessing should be checked. Because now, if you look back at the development of ERCP scopes, and they started to be developed like 20, 25 years ago. In the meantime, what they call like 20 very small changes have occurred. But if you now compare the last type of ERCP scope with the first one it's a world of difference. And nobody ever looked into the whole issue of whether that scope then could be cleaned adequately, yes or no. So these are my last slides, and I hope to see you maybe again next time when we have the results of the DTEC study. Thank you very much.